Okay. Yeah. It's really a pleasure to have Dr. John Danchik with us today. I've known John for a long time, from his first days in practice in Massachusetts. And John has gone through some tremendous, what I consider to be transitions in his career. And so John, if you could kind of share with the viewer the way it was and the way it is, would you share that with us?
Sure. It's funny you say the way it was. Being in practice now over 30 years, those first 26 years were all by myself and running a practice, everything from, like I like to say, from buying paper clips to running the payroll to paying my taxes on my own, doing my corporates. I did everything from being a sole practitioner to a PC corporation, back to a sole practitioner. Had people work for me, had associates, had muscular therapists, and it got to a point where it was work. It was not fun anymore. It was work. And I was fortunate enough after 25, 26 years in practice to get what I finally wanted. And that was to get involved in a integrative / collaborative practice. And I've been doing that for the last 6 years. In saying that, the most difficult thing to do in making that transition was an emotional attachment that I had with my practice I had to let go. It was difficult to let go of something you built with your own hands, and now all of a sudden you were going to transfer that into a group-like setting. So it was difficult. I made that transition. We're starting our 6th year in the integrative practice that we're in now.
Can you describe that model that you're in, and how did that all happen?
We're in a group now where we have 10 different disciplines, everything including, I'm not going to mention them all, but from podiatry to gastroenterology, dermatology. But the primary practitioners there are internists, and there are 9 internists. In total, we have 23 different physicians. It was fortunate. I made some very nice relationships with doctors in the community, which I practiced through the years. Relationships that were built on trust, relationships that were built on good treatment of the same patient. And they asked me if I would like to join their group about 10 years ago. And I said no. I had that emotional attachment that I talked about. I didn't want to let go. I just didn't want to let go of something I built. As the years went by, they asked me about every other year, once again, if I wanted to join their group. They would love to have me. They wanted to have an integrative practice. And I continued to hold off because, again, it was difficult for me to do. However, it gets to a point in practice where you get a little bit tired, you get a little burnt out of doing the mundane things. And this was an opportunity to change.
I think in a conversation that you and I had several months ago, you had indicated that the senior doctor in the group who you had become friendly with had indicated to you that said, John, if you don't come into our group, we're going to get another chiropractor to come into the group. And I think that kind of graphically demonstrated to you the seriousness of their pursuit.
Absolutely. That was a commitment that I knew that they were willing to make. It wasn't they were just trying to be nice to me. They were going to move forward. They gave me one last chance because they, out of respect, they said, John, we want you, but if you're not going to come, we're going to go somewhere else.
When you made the transition, when you finally left the comfort of your cocoon, if you will, and you went into the group's setting, which I guess is not far from the grounds of the Mount Auburn Hospital.
That's correct.
That transition, how was the transition in terms of the physicians in the group recognizing the presence of a chiropractor and knowing when to refer patients to you? How did that take place?
Well, it's funny you say that because I prepared, I did my homework, and I prepared a nice presentation, not only a clinical presentation, but a business presentation to them as I required, and they required also, that we meet one day. and we got into a conference room, and I had done my background work and realized that the primary care physicians, the internists, the family care physicians do not really get a good musculoskeletal background in medical school. And so I started in on my program, and I know that you individuals don't have much of a background, and right away they stopped me. They said, well, John, you're here because we want you to be here. You don't have to prove something that we already know. We have patients, and those patients have back pain, they have neck pain, they have shoulder pain, and the best we can do for them is to medicate them. And the orthopedist doesn't want them sent to them because unless they're a surgical case. So our patients are kind of in limbo. We want something better for them than just to medicate them and feel better. They come back in 6 months and we medicate them again. You have a service that we want to utilize with our patients.
So I think as I talk with a lot of young chiropractors, I've often thought that new patients have been the cocaine of chiropractic, so to speak. You can't get enough new patients. And I think there are literally the majority of new patients are in physicians' offices or in the medical doctor's offices. And it seems logical to me that by building the bridge, by building the relationship, that the worry, if you will, for new patient referrals becomes much different than when you were in the safe confines of your practice. Could you tell me how that may be different?
It's significantly different. As you so well stated, there was always the stress of where the new patient was going to come from and how you had to motivate yourself, or use that term, market yourself, to have to get that new patient to be there. That's not even an issue now. The new patients are already come into the primary care physicians' offices. They just refer to us. We told them what we've had to teach them what a proper referral happened to be.
Right.
And there was a little in-house education that had to take place because, quite honestly, they really didn't know the types of situations that we could treat. So we did some in-house marketing, and by marketing I want to say educating, of the primary care physicians of the typical cases that we can handle. Once we did that on a weekly basis for a year. We would send out what we call musculoskeletal minutes, and we would self-educate them a little bit, very one-page brief notices of diagnoses that were common.
Right.
And it was a self-education, self-motivating process, and it really revealed dividends in terms of our practice.
Did you find that maybe there were more trusting relationships that built between you and the medical staff in the group, meaning that it just fit like a glove, I guess, after a while?
It really did. It's amazing how acceptance was there because you were a member of the group. And once you were a member of a group, they accepted you. As time went on, and they would see the patients, and the patients could be returning back to the offices with positive results. It was only a matter of time when many of those doctors became patients.
And I think what didn't matter any longer was what initials you had behind your name.
Very few of us even refer to each other as doctor. Or,
right.
You know, it was just really we all worked for the same group with the same purpose in mind, and that was to be patient-centered.
Can we move to another area? I'm thinking about the possibility that many people who might be viewing this could be students in chiropractic school. They may be folks in the first 10 years of practice. There are changes that are taking place out there. I like to think of it as a new paradigm where we build collaborative relationships, where we look at how can we complement the services that are out there. If you were going to give counsel to someone who's currently in chiropractic college or who may be new in practice, what kind of a mindset should they have? What is it that you think they should be preparing themselves to do to move forward into what I consider to be the new age as you're currently doing?
I'm actually not concerned about the individual student and the clinical skills. I believe they will graduate with very good clinical skills. I'm more concerned a little bit about their people skills, and by that I mean how they are going to be able to relate not just to patients, but to relate to other professionals of different disciplines. I think that we should. I think my concern is how open are they going to be to going out and meeting the public, going out and meeting the practitioner other than the chiropractor in the community in which they're going to practice. There have to be ways to let that particular individual know what their clinical skills are. Mm-hmm. There has to be a way for that individual that's going to practice or wants to practice in a collaborative way to know what the benefit is going to be to that group mm-hmm. in which they want to practice. So not only do they have to have, once again, I'm not worried about their clinical skills, I'm more worried about their business skills. I'm worried a little bit about a business plan as to how they are going to help an existing practitioner who is already established, cover the overhead, how they are going to complement that individual's practice. And they have to get to know themselves and what their strengths and weaknesses happen to be.
And I think a part of that is what I call interpersonal or intrapersonal intelligence. That is knowing yourself, knowing what your strengths are, knowing what your weaknesses are, and being very candid and frank with yourself in regard to those things. But also your ability to be able to communicate verbally and non-verbally with another individual, and to be able to do that with success. And I think, if my question is right, it's probably how do I prepare myself for being able to graduate from college, to graduate from chiropractic school, and to be able to move in a direction that you have gone in, and where literally many, many, many other doctors today have gone. What further thoughts might you have on that?
You know, going all the way back to the days of Cub Scouts and Boy Scouts, the old terminology was to be prepared. And,
yes.
and I could even carry that into playing sports. You always wanted to be prepared. You want to know as much as you could possibly know about your opponents, so that you were. And then thirdly, you want to know what your strengths and weaknesses were before you went into battle.
Right.
Well, you know, whether you're having a one-on-one meeting with another physician in town, or whether you're meeting with a group, or whether with a hospital, do your homework and get as much background material on that individual, that hospital, that group that you possibly can get, so you know as much as you know about that particular individual.
And I think your role, at least as we've looked at it as an expert within the IHCPR group of experts, is to be able to provide that kind of counsel for someone who may be going into practice or who has just gone into practice and needs to be able to develop a better understanding of how this world, if you will, that you are involved with, how that can work more effectively.
Absolutely. I'm just one spoke in the wheel. There are many, many individuals out there that have the same type of relationship that I have, but they went about it a little differently than I did. But the goal was to be in an integrative type of program, and we're fortunate that we're surrounded by good individuals to give guidance. Great.
Well, I think that's phenomenal. Great.